It's my pleasure to introduce Dr. Chris Ryerson from the ILD clinic at St. Paul's Hospital. And I think many of you know Dr. Ryerson. And he is a professor of medicine at UBC, director of the St. Paul's Hospital ILD Clinical and Research Program, and head of division of respiratory medicine at Providence Healthcare. His research focuses on diagnosis, management, and prognostication of ILD. He is also involved in several national and international clinical practice guidelines on the diagnosis of and management of fibrotic ILDs. So, welcome, Dr. Ryerson.
All right, thank you. All right, this is classic Daniel. He's always a couple minutes late. And now he's got a tough act to follow, which is even worse. All right, so what is new in pulmonary fibrosis? The answer is lots. So we've given this talk in the past, or this kind of talk, and often we don't have too much to say, but this year we actually do, which is nice. I have a bunch of disclosures. The more things you have on this slide, the more important you are. So I got lots of things here. And the nice thing is about conflicts of interest, if you've got so many, they cancel each other out. We'll talk about some of the medications made by some of these companies, but we'll stick to the evidence. This talk, we're going to go through some new diagnostic and classification standards, the current treatment landscape, and the evidence behind upcoming treatments, and then how to get involved and self-advocate. So just a tiny bit of stuff on that, and we can maybe talk about more about that as well. So we'll just jump right into it. So diagnosis and classification, there is a document that's just been published that will kind of percolate through the field over the next couple of years. And there may be some implications for patients as a result of that document. And there are a couple of things, 2 or 3 things that I wanted to draw attention to. And this is just to give you guys all a background on what we struggle with, so that when we use ambiguous terms or conflicting terms, it's not because we're all idiots, it's because we sometimes have evolution of things and things are complicated. So the first thing that's really important is to distinguish between the pattern that you see on a CT scan or sometimes on a biopsy if you have a biopsy. So there's a morphologic pattern, and then there's a multidisciplinary or a clinical diagnosis that integrates that pattern with all the other stuff that's going on. And there are a whole bunch of different acronyms that the field is plagued with, including things like UIP and HP and NSIP and so on. And those have been described as patterns, but then there are also clinical or multidisciplinary diagnoses. And depending on whether we're talking about your CT scan pattern or your diagnosis, we might use different terms that have some overlap. And there's a lot of overlap between pattern and diagnosis as well. So the pattern that you can see, so let's say we look at your CT scan and you have a UIP pattern, like at the bottom here on the left, that's a typical UIP pattern on CT scan. And depending on the clinical context, that person might have rheumatoid arthritis causing their lung disease, an RA, rheumatoid arthritis, or they might have idiopathic pulmonary fibrosis if they don't have an underlying cause of their disease. So depending on what company that pattern keeps, there may be a different diagnosis. And one of the things that the field has struggled with is conflating or confusing pattern and diagnosis. And the field historically has focused on diagnosis as our treatment kind of fork in the road, but increasingly I think we're starting to think about pattern, and we'll come back to that point in a sec. The other background piece of information that's relevant for this discussion is about disease behavior, so how the patient is progressing over time. Or their prognosis in terms of the progressive fibrosis that they experience, and sometimes the amount of inflammation that they also can experience at the same time. In this previous document from a decade or so ago, there are a bunch of different patterns of disease behavior that are described. The main one that we focus on now is how much progressive fibrosis you've got, because that's going to be a progressive condition, versus how much inflammation you've got, which is treated in a different way and has a different outcome as well. So as an example, patients who have that UIP pattern, regardless of the underlying diagnosis, they're more likely to have progressive and often irreversible disease. Whereas somebody who has an NSIP pattern, which stands for nonspecific interstitial pneumonia as opposed to usual interstitial pneumonia, people with an NSIP pattern have a bit more inflammation and greater potential for improvement if you treat that inflammation, and then they have usually a slower progressive fibrosis picture in the longer term. So that disease behavior, we can observe that based on what we've seen in a patient, but we can also predict it based on what we see on the CT scan and sometimes what we see on other features. And a lot of the time, that's what myself, Dr. Manouk, Dr. Marinescu, and so on, that's what we're doing, is looking in clinic and trying to guesstimate what your future path is going to look like and treating you accordingly. The third thing I'll mention is diagnostic confidence. This is a paper from Daniel Marinescu a couple years ago. And the only thing I'm going to draw from this is that there are a whole bunch of different patterns that we see. That's what each of these bars represents. And within those different patterns, we see different diagnoses. And importantly, in the gray at the bottom, a good proportion of patients have what we would call an unclassifiable interstitial lung disease or unclassifiable ILD, where we're not really sure what the underlying cause is. And a lot of people find that quite distressing when we say we don't know what is causing this. Having said that, we do know with reasonable confidence how to treat it. So even if we don't know the cause, we often know the treatment that makes the most sense. But that does end up being distressing for a lot of patients to say we don't know what caused this. There are some upcoming, well, actually just published documents on the diagnosis and classification of pulmonary fibrosis, and these were just published a couple weeks ago. And these provide some updated terminology, fixing some of the idiosyncrasies or some of the maybe errors of the past with what we know now, and there's a more rational organization framework. And I'll just show one slide on this. This is kind of a scaffolding that's supposed to explain where all of the different 200 different subtypes of interstitial lung disease fit into one big framework. So this is how it all comes together. We focus on patterns in the colored cells on the left, and then different diagnoses, different causes in the white and gray parts on the right side of this figure. And all interstitial lung diseases essentially can now fit into this framework. So it's a more organized way of approaching things than the cobbled together flow diagrams of the past. So the question is, what does that mean to you guys? Probably nothing at all. This is more helpful for us. But you might see slightly different terms used to describe the pattern of disease that we see on the CT scan, or sometimes even the diagnosis. And that doesn't really change too much. It's really just giving us the right terms to use for your condition, so that when I'm talking to people in Europe or in the rest of Canada, or I don't talk to US people much anymore, but we are talking the same language, and we're able to pool our patients together and better study the rare conditions that you really do need these global studies to learn more about, or at least national studies. And then from a patient perspective, you'll have fewer inaccurate terms assigned to your medical record. Sometimes smoking is not a great thing to be doing, but some of these things are smoking-related lung diseases, but they're also sometimes not related to smoking. And sometimes in the past we've said, you've got a smoking-related lung disease despite you never being a smoker. And that can be a little concerning to patients as well, to have labels like that. Or you've got an exposure in your environment that's causing your lung disease, but you don't actually have an exposure. That ends up being confusing when we use those conflicting terms. So again, this is improved and more consistent terminology for us, for clinicians and researchers. It's easier for us to teach it to the next generation, which hopefully will lessen some of the confusion that we've experienced over the last several decades. And again, it facilitates communication with other clinicians, other researchers. And we're also better acknowledging uncertainty, which is nice in that it directs us to certain parts of our lack of knowledge, where we need to direct efforts to learn more either about that individual patient or to study on a more global basis to generate research, new knowledge, and improve patient care. Okay, so moving along to the currently available treatments, I just have a couple slides on this. So this is a slide that shows the benefit of nintedanib in patients with IPF. Nintedanib is also referred to as OFEV, which was the trade name, and that's coming off patent later this year, I believe, after which we'll just be calling it nintedanib, which I've tried to use that term for now. So what this slide shows, this is kind of spotty, but on the y-axis, we have your lung function, and then on the x-axis, we have time. And what it shows is that compared to baseline, if you're on the placebo, which placebo just means basically it's a fake pill, it doesn't do anything other than tricks you into thinking you might be on a drug. So if you're on a placebo, you decline by about 200 milliliters over the 52 weeks of this study. If you are then given the drug, you drop that rate of progression by about half. So slows the rate of progression by about 50%, being on the drug compared to placebo. This is the pirfenidone equivalent. They did some slightly different statistical analyses things. The death equals 0 is what that refers to. And so their numbers they look bigger as a result. So patients declined here by 400. But the point here is that you also have about a 50% slowing in the rate of progression over the 52 weeks of this trial. So both nintedanib and pirfenidone in IPF slow progression by about 50%. They don't stop it, but on average, they slow it by half. So that has led to antifibrotics. Nintedanib and pirfenidone are both antifibrotics. They are the standards of care for patients with IPF, usually, well, always one or the other of the two. We don't use them in combination. So that's IPF. If you have something other than IPF, so this would be things like an autoimmune condition or hypersensitivity pneumonitis, unclassifiable ILD, et cetera, usually what we are doing, in the past anyway, is using immunosuppressant medications or immunomodulatory medications that calm your immune system down with the thought that your immune system is overactive and causing some damage to your lungs. And the medications that we use for that are on the right, so things like mycophenolate, azathioprine, rituximab, tocilizumab. In the olden days, we would sometimes use cyclophosphamide, and then there's a few others as well that sometimes we use. Sometimes prednisone, more in the acute setting as well, and these other ones that I've listed here are more long-term medications. There is not that great data for most of these things, but most of them are used based on historical precedents, and we do see benefit of these when we look at the data that are there, and then also some anecdotes from our own experiences with patients where clearly they did benefit from treatment. More recently, we've seen that these same medications for IPF, nintedanib and pirfenidone, they also work for patients with non-IPF interstitial lung disease as well. So there's good data now suggesting that if you progress despite these immunosuppressants, we can use nintedanib and pirfenidone to treat the fibrotic part. So what we've got now is we've got that upstream inflammatory part that's treated by these immunosuppressants that calm inflammation, and then we've got the downstream scarring that's treated with the anti-scarring medications, nintedanib and pirfenidone. So this is kind of where we're at right now. This side of the algorithm is pretty clear. But this side of the algorithm, there are actually a bunch of questions that we're not 100% sure of the answer to. First is that there are probably some patients where immunosuppressants aren't the best first option. People that might have short telomeres, which is a blood test that we don't routinely do in clinical practice at this point in time, but patients with shorter telomeres maybe don't have as much benefit and maybe they have greater side effect complications from immunosuppressants. Number two, it might be that we should be switching this around and maybe the antifibrotics should be the first line for at least some patients. And maybe we should be using both at the same time rather than thinking about one and then the other. And then there's another question about who doesn't need treatment. And there are lots of patients that we don't treat up front and we monitor for progression and see how they go because they've generally got mild abnormalities, but we're not perfect at predicting that at this point. So that leads us to new treatments for pulmonary fibrosis. And I'll say finally, because we've been talking about these new treatments coming along for a little while, and there have been some failed clinical trials along the way, and now we've finally got a couple positive ones to be more excited about. So the first one is Nerandomilast. That's the generic name. I'm not sure what the proper trade name is going to be that the pharmaceutical company will be advertising, but Nerandomilast is the name that we will be using. And showing the same figure as before, patients on placebo have decline over time, so that's the placebo down here. And patients who are on the low dose and the full dose of Nerandomilast have relative preservation of their lung function over time. It's not quite that 50% benefit that we saw in the original studies. Having said that, the patients who are in this trial, a lot of them are already on those initial therapies. So this is now add-on. So we got 50% benefit of the first ones and another 40% after that. And so we still have some improvement to go before we reach this horizontal line of stability, but we're getting further and further up. The other thing to note is that patients coming into these clinical trials are often the ones who are not doing well. So these patients are often progressing over time, and this is kind of not quite grasping at straws, but trying to find something that works when everything else is not working. And this is nice because it shows that Nerandomilast is a medication that works in that situation. There's some interesting breakdown of subgroups. So I'm not going to spend too much time on this, but we can come back to it if people are interested. But on the left, these are patients who were not taking any antifibrotic medication at baseline. And it shows that Nerandomilast is beneficial. So placebo over here, patients are dropping their lung function by a bunch, and adding Nerandomilast, you reduce that drop by about half. Patients on background nintedanib, they're not doing as well generally at baseline. They're dropping faster. And these are patients who are dropping quickly. They're on nintedanib. They're not super happy with the way things are going, and so they get brought into a clinical trial. And Nerandomilast provides some benefit in addition to the nintedanib, so it can be used in combination therapy. This one on the right is the more interesting one. So patients who are on background pirfenidone, the low dose Nerandomilast has no benefit compared to placebo. You need to be on a higher dose for it to have benefit, and that's probably what seems to be because pirfenidone and Nerandomilast have what's called a drug-drug interaction, where the benefit of Nerandomilast is reduced because pirfenidone does stuff to the absorption of that medication into the body. So if you're going to be on the combination therapy in the longer term with pirfenidone, you need to be on the higher dose of Nerandomilast to have any benefit. So the other really good part about this drug is that we see it's beneficial, but we see a whole lot better side effect profile. For those of you on nintedanib and pirfenidone, we say somewhere between maybe a third of patients have no side effects. And in Nerandomilast, the vast majority seem to not have significant side effects. So diarrhea is the main one with Nerandomilast. But interestingly, these numbers are maybe too small, but the diarrhea is really only happening with any frequency in patients who are already on nintedanib, which we know causes diarrhea in a lot of people. And so if you're just on Nerandomilast by itself, a couple people get diarrhea from it, and then there are no other side effects that are reported at this point, which is, as a lung doctor, really nice to not have to tell people what to do about diarrhea anymore. So some concluding thoughts about Nerandomilast in IPF is that it slows the rate of decline, including when added to background therapy. There wasn't a clear benefit on mortality, although this is a shorter clinical trial, and I'm sure longer term there would be a benefit. There's no clear evidence of benefit of acute exacerbations, but same kind of idea with that. Those are rare events, and it's hard to detect a benefit in a clinical trial like this. And then there's no clear benefit on symptoms, which is consistent with every other previous clinical trial, that there's really minimal benefit on symptoms. And that's an interesting thing that we can chat about later potentially. The main side effect is diarrhea, which was 2 to 2.5 times higher than in placebo, but still pretty uncommon numbers overall. And really it was the patients on background nintedanib that seemed to have the most difficulty. There's that maybe drug-drug interaction, well, more than maybe, there is a drug-drug interaction with pirfenidone that will potentially change the dosing when we use it in combination. Having said that, I suspect that the funders will likely not allow us to use it in combination, and at least initially. I suspect that it will be considered a substitute for existing therapies. If you're not doing well on nintedanib or pirfenidone, you can then switch to nerandomilast. We'll see if the funders allow us to use it in combination. That's what we would probably like to do, but we may not be allowed to do that for funding reasons. All right, so moving on to nerandomilast in what's called progressive pulmonary fibrosis, or PPF. And so these are diagnoses other than IPF. So again, this is your hypersensitivity pneumonitis, autoimmune conditions, unclassifiable, interstitial lung disease, and others. And we see essentially the same kind of thing. So same curve, same figure, where placebo does worse, nerandomilast does better. So both doses of nerandomilast reduced the rate of FVC decline. Patients are typically not on pirfenidone in this kind of situation, so we only have background nintedanib being used, and we see benefit of nerandomilast, again, regardless of whether you're on nintedanib or not. Interestingly, we do see some benefits of nerandomilast on acute exacerbations and death, which we didn't see as obviously in the IPF trial, but the way this works is when we talk about acute exacerbation of ILD or death, there was about a 40% reduction. That's what this 0.59 means, is a 41% reduction in the rate of acute exacerbation or death. And same thing down here for death, this 0.48 means that there was a 52% reduction in the rate of death with nerandomilast compared to placebo. The frequency of acute exacerbation and death is small in these kinds of trials because you don't bring patients into these trials when they're close to that terminal event. But this is still impressive and something that we haven't usually seen in previous clinical trials. This is really positive to see here. Again, diarrhea was the only clear adverse event, a little bit less frequent than in IPF for whatever reason, and again, very similarly, really in patients who are on background nintedanib. So some thoughts about nerandomilast in non-IPF progressive pulmonary fibrosis is that it works. It slows progression, including when used by itself or when added to nintedanib. There wasn't any clear benefit on symptoms, but acute exacerbations and mortality seemed to be improved with this one. Main side effect is diarrhea. Again, relatively minor in terms of the severity, especially compared to nintedanib. And same kind of idea, I'm not sure that we'll be allowed to use this in combination, at least initially, but it is a viable therapy used either alone or in combination, and we'll see what the funders end up saying. So the last new clinical trial I'll talk about is inhaled treprostinil in IPF. This is a trial that we were participating in at St. Paul's, and I think VGH was as well. And this is an inhaled therapy that was given a couple times a day, I think. And we haven't seen the full publication of this, but the press release and the presentation last week at a conference or earlier this week at a conference, showed that inhaled treprostinil was better than placebo in changing FVC over time. So similar magnitude of benefit of the other drugs. And this is a very different mechanism of action. So again, the thought is that this would be able to be used in combination with other therapies. Again, we haven't seen the actual publication, so there will be some more details to follow. What was also reported in the press release was that there were significant improvements also observed in secondary endpoints. So FVC is a primary endpoint, and then there are a whole bunch of other things that they look at. And this included quality of life and DLCO. And usually, these two endpoints are not improved by drugs that we study. So this is quite positive. The main side effect appears to be cough, which worsened in about half of patients with this. And I have seen patients that have really struggled with cough, and so that may be a reason to not continue on with this medication in some patients. But overall, seemed to be okay tolerated and clearly seemed to be associated with benefit. Again, this is not published yet. There's another PPF clinical trial going on that's not done enrollment yet, but probably will be by the end of the year. And I think people will be interested in seeing that that one, and the expectation will be that that one should also be positive given how positive the IPF trial was. There are multiple other clinical trials going on and upcoming at St. Paul's and VGH. These are all focused on IPF or other conditions that have had progressive fibrosis. But the hope is that as we get more treatments, better tolerated treatments, we'll start being able to use those treatments earlier in the disease. And kind of coming back to that disease behavior concept before, I would love to be able to predict whether you're going to have progression and start treatment then, rather than waiting to observe progression and only start treatment after you've already progressed. That's a window of missed opportunity. The trials that we're involved in at St. Paul's and VGH are usually phase 2B or 3 trials, and this is the usual kind of study description, is that we get a patient on the left. We think you might be appropriate for a clinical trial if you're interested. We take you through a bit of a screening visit. That's what the S is. And then from there, if you meet eligibility criteria, we go to a randomization visit. And then you get either the placebo in blue or the medication in green, and you proceed through this list of study visits. Usually it's monthly for the first few months, and then it's usually every 3 months after that, although it depends on the study. And then the end of study visit, usually that's at the end of a year of treatment, although sometimes it's 26 weeks. So that's a phase 2B/3 study. Sometimes we also get involved in phase 3B or phase 4 clinical trials, and same kind of idea, except usually in that situation, it's a drug that we know works, but it's not yet on the market. So as an example, Nerandomilast or inhaled treprostinil for IPF at least, we know those drugs work. They're not approved by Health Canada yet, but sometimes we get involved in what's called open label studies, where everybody in the trial gets that medication, and we usually have a more simplified study protocol because we've already done that efficacy kind of thing, and now we're looking at maybe a specific side effect or something else, and so it's a simplified study protocol with just a couple visits often. And the nice thing about nice thing about all of these trials is that if the drug works, you continue to get the medication afterwards as well. So if you're interested in these kinds of things, ask your doctor. I would say about half of the patients have some clear reason that they can't participate in a clinical trial, and we've looked at this before, and right off the bat, half of people just it's an absolute no. And then of the remainder, there's often some kind of other reason, whether it's geography or social circumstances or something else that make it harder for patients to participate. So how to get involved and how to self-advocate, I think one of the key things is just start by asking your doctor what they think. And for now, these new drugs aren't on the market, but there are clinical trials that you can be considered for. Keep an eye on the news. When these trials come up, ask your doctor if you might be appropriate for this new therapy or one of these new therapies. In the meantime, advocation, so advocate for approval, for funding coverage, and people who are here know better than I about how you can do that best. Let's see. As I've got on the right side, we have already determined the safety, the benefit of a new drug for Nerandomilast as well as for inhaled treprostinil, and now we're waiting for approval of those therapies, and we're waiting for that for Nerandomilast. Inhaled treprostinil has not been submitted to Health Canada yet, but the hope is that that will happen in the not too distant future. Nerandomilast, I would be hopeful that it's approved by Health Canada maybe by the end of the year or early next year, and then it goes to the provinces and the extended health plans to decide who they're going to cover that medication for. And that might take another 6 to 24 months, depending on which province you're in. If you live in British Columbia, it usually takes closer to 24 months. All right, and that's why advocating is sometimes helpful, because BC is typically slow. So what else can you do? Look after yourself, accept help when needed. I think there were some talks earlier today that cover this much more than I will with this one slide. Make sure you're educating yourself, you're taking that first step today, or maybe it's the next step is today. Advocate for yourself and for others, and then help us learn more, as was mentioned before. Participating in research is a great way to do that. Fundraising is a great way to do that as well. There are lots of other ways to get involved. So to summarize, there are new diagnostic and classification standards that your doctor will be incorporating into how they talk about you in your clinic notes and stuff like that. Importantly, the current treatment landscape is going to significantly change in the next couple of years. Hasn't changed right now because these drugs aren't available at the moment, but they will be within the next year or two. And then continue to be involved, ask lots of questions, advocate for yourself, participate in research. Don't be afraid to bring questions to your doctor. I had one patient yesterday who brought a list of 33 questions that we went through in clinic. So that's on the long side, but we did make it through that even. And with that, I'll stop and say thank you to all of you for being here. And I'll say thank you as well to the Canadian Registry for Pulmonary Fibrosis, all the doctors that are participating in that, and especially all the thousands of patients that have contributed data for that as well. So thank you again.